Hello everyone, this is Dr. Gobind Rai Garg. In this video, we will discuss the recall questions which were asked recently in NEET PG 2024. So I have combined the questions of both Shift 1 as well as Shift 2. So together we will discuss all the questions. So starting with the first question. Which of the following cardioselective beta blocker has been shown to decrease mortality in patient with CHF? So which beta blockers decrease mortality they are asking. Remember which beta blockers that are approved in congestive heart failure. They are approved only in chronic CHF. These include metoprolol, bisoprolol and carvedilol. So only 3 beta blockers are approved in treatment of congestive heart failure. And remember the drug which decrease mortality are mainly renin-angiotensin pathway inhibitors, including beta blockers, ACE inhibitors, ARBs, and angiotensin receptor blockers. So among these, the option contains bisoprolol. So that is the answer. Okay. Now, second question, a patient with mild to moderate renal failure require reversal of muscle relaxation caused by V-curonium. Remember the reversal agents which are used in anesthesia for the muscle relaxants, after using the muscle relaxant, they may be neostigmine and that may be sugammadex. So we all know about them. The basic difference between the two to remember, neostigmine is a cholinergic drug. It inhibits acetylcholinesterase, so that will act by increasing acetylcholine. Whereas sugammadex is a selective relaxant binding agent. It will selectively bind to muscle relaxant and stop their action. By increasing acetylcholine, it will cause cholinergic side effects. So there will be cholinergic side effects of acetylcholine, whereas these side effects are absent in sugammadex. Now it can be used, neostigmine can be used for all muscle relaxants, all non-depolarizing muscle relaxants, whereas sugammadex is mainly for V-curonium and rocuronium. Sugammadex is a faster acting agent than neostigmine, and sugammadex is contraindicated in severe and end-stage renal disease, whereas it can be used. So if we see the question, neostigmine is not in the option, so the answer directly becomes sugammadex. You may get confused by renal failure, but they have specifically mentioned mild to moderate. So mild to moderate we can give sugammadex, in severe we cannot give. Clear? So the answer is easy because neostigmine is not in the option, so the answer becomes sugammadex. Okay. Now next question, aprepitant is a drug used in treatment of chemotherapy-induced nausea vomiting. What is the mechanism? So first of all, the drugs end with patent, like aprepitant. These are drug of choice for delayed chemotherapy-induced nausea vomiting. These are basically substance P antagonists. Substance P is a basically type of neurokinin. So these directly bind to NK1 receptors of the neurokinin and block them. So they are NK1 receptor antagonists. So they are named as substance P antagonist. So they act by inhibiting substance P, that means neurokinin 1 antagonist. Okay. Next question, which is an inclusion criteria for shorter bedaquiline regime? Now, first of all, where we use shorter regimes? Remember, normally for drug-resistant tuberculosis like XDR TB, pre-XDR TB, MDR TB, we tend to use a longer regime, which is running for around 1.5 years or even sometimes more. So, in between a regime came which is shorter regime that is used for around 9 months period. But there are specific conditions where it can be used. So this shorter bedaquiline regime, it is indicated, number 1, either in rifampicin resistant or MDR patients of tuberculosis. Second, when we say MDR, there is a resistance to isoniazid. But isoniazid resistance can occur due to 2 reasons. Either there may be mutation of INHA or there may be mutation in CAT-G. So what is important is shorter regime can be used if there is mutation to any one of them, but if there is mutation in both of them, then we should not use shorter regime. So any one resistance. Then third, it is not indicated in severe disease, so it is only for pulmonary tuberculosis, and that too mild to moderate pulmonary TB, not for extra pulmonary tuberculosis. Yeah, so these are the important guidelines where we can use the shorter regimes. Now coming to the options, extra pulmonary TB, no, we are using it for pulmonary TB only. Rifampicin resistance with both mutation, no, it is not rifampicin resistance. Rifampicin resistance is already there. Plus both mutation, that means it is MDR TB, but because there are both mutations, we do not use. If only one mutation was there, we will use. Rifampicin sensitive, it is not indicated in the rifampicin sensitive TB, it is indicated in rifampicin resistant TB. Rifampicin resistant but fluoroquinolone sensitive TB, so it may be rifampicin resistant TB, and if it is resistant to isoniazid also, it will be MDR TB. So this is the indication of giving bedaquiline shorter regime. Okay, so do not get confused that the option B is MDR TB. Yes, it is MDR TB, but when there is a mutation of only one gene, then we use bedaquiline shorter regime. Otherwise, we have to use a longer regime. Okay, so answer is D here. A patient is found on a railway track with hot, dry skin, raised temperature, dilated pupil, slurred speech, staggering gait. What is the likely cause? So these are the typical features of Dhatura. So if you see typical features of Dhatura, so Dhatura says, it says dryness, dilated pupil, hyperthermia, agitation, tachycardia, urinary retention, and accommodation is lost, leading to blurred vision. So what are the features which are suggesting this? We have hot, dry skin, dryness is there, hyperthermia is there, dilated pupil is there. So all these point to Dhatura poisoning. Now do not get confused with a slurred speech and staggering gait. They can be seen in alcohol intoxication. Yes, they can be used, but in alcohol intoxication there is typical hypothermia. There will not be hyperthermia. There is no point of hot, dry skin in alcoholism. Yeah, so dilated pupil is also usually not seen. So it is a typical case of Dhatura poisoning. Okay. A woman at 8 weeks of gestation is diagnosed with hyperthyroidism, which is this is easy. 8 week means first trimester, and we already discussed several times PTU. PTU is पहले trimester में use करना है. So answer is propyl thiouracil. Next question. A woman at 30 weeks of gestation is diagnosed with DVT. Which drug is most appropriate for prophylaxis? So remember, for anticoagulant in pregnancy, the drug of choice in every trimester is low molecular weight heparin. So unless any other problem is there, we should use low molecular weight heparin. So for treatment of DVT also and for prophylaxis also, both of them we use low molecular weight heparin. So the answer directly become low molecular weight heparin. Now there are things that some people say that warfarin can be used in second trimester. Yes, it's absolutely right. Warfarin can be used in second trimester up to 36 weeks. But important thing is it can be used. But if we want to use, we will prefer always low molecular weight heparin. So warfarin can be used. Second important thing to remember, there is no point like fondaparinux is used in pregnancy. No, the drug of choice is always low molecular weight heparin. Yes, fondaparinux has lesser risk of causing head, and that is same as in a normal population as in pregnancy. So due to pregnancy, there is no difference. So answer is easy. It is low molecular weight heparin. Okay. Which is represented by drug X. So drug X, basically it inhibits streptokinase. So which is a drug which is antifibrinolytic, and we all know two drugs. One is epsilon aminocaproic acid and second is tranexamic acid. They are inhibitors of streptokinase like drugs. That means antifibrinolytic. So that is EACA. Next question. A patient present with hypertension. He has history of renal stones and experienced few episodes of renal colic. What is the most appropriate diuretic? So we discussed this several times. It is called loop loses calcium and thiazide are opposite. So question is where they lose the calcium. So if we see, this is our kidney, this is the blood. So loop loses calcium means loop diuretic will lead to movement of calcium in the kidney. They will lose in the kidney. So loop diuretic increase calcium movement in the kidney. So when there is more calcium in the kidney, there is more risk of renal stones. On the other hand, thiazides, they increase the movement of, decrease the movement of calcium from the blood to the kidney. So although the calcium increase in the blood, but it will be less in the kidney. So when less calcium is excreted, less risk of stone formation. So paradoxically, it seems that thiazides are causing hypercalcemia, but still they are used in renal stones because they are causing hypercalcemia by preventing the movement of calcium in the kidney. Okay, so the answer to this is hydrochlorothiazides. This we have already discussed in our videos. Okay, next question. Which of the following is most appropriate treatment for an overactive bladder in a patient with dementia? Now, important thing, first of all, we need to see which all drugs are used in overactive bladder from the options. If you see the options, only one drug, tolterodine, is specifically used for bladder. Other drugs like tiotropium is inhalational drug for asthma. Tilanzapine is a drug which is M1 blocker for peptic ulcer, and tropicamide is used as eye drops for producing mydriasis. So other three drugs are not used. So the answer will become tolterodine here. But important to remember, tolterodine is anticholinergic, and anticholinergic drugs are usually avoided in Alzheimer's disease. Had there been some better option, so I was searching that, had there been mirabegron in the option, that would have been the best answer. But mirabegron was not in the option. Among the anticholinergic drugs, if trospium is present in the option, that will be the better answer because it has minimum CNS entry. But that is not in the option, so answer will be tolterodine. Just remember, trospium will be better answer because it is anticholinergic but less entry in the brain. Okay, so among these, answer will be tolterodine. Next question, which statement regarding the patch used? So what is the patch here? In the name it is written amla. So it is a patch of amla. So what is amla? Amla is a eutectic mixture of local anesthetics. So which local anesthetic? It is a mixture of two local anesthetic, lignocaine and prilocaine. Both of them are present in a concentration of 2.5%. 2.5% lignocaine, 2.5% prilocaine concentration, and at the normal in the temperature, this cream in the patch, they are presented in usually in the liquefied form. Now what is important that these are present in equal concentration. They are used locally for producing anesthesia. Now coming to the options, equal mixture of local anesthetic, no, they have played the game by writing equal instead of eutectic. Second, contain lignocaine and ropivacaine is wrong. It contains prilocaine. 5 ml of 5% mixture contain 50 milligram lignocaine. If you see, if it is 5 ml of 5%, so 5% means 5 gram is present in 100 ml. So if we calculate in 5 gram means 5000 milligram is present in 100 ml. So that means 1 ml will contain 5000 by 100, that means 50 milligram. So 1 ml is containing 50 milligram. So 5 ml will contain 250. So this is also wrong. So answer here is prilocaine we know can cause methemoglobinemia. Although the risk is much lesser, but in infants and in at-risk patient, there is risk of methemoglobinemia. Okay. Next question, which chelating agent is contraindicated in iron poisoning? So that is a stat question we discussed. Cafe में बाल नहीं होना चाहिए. So बाल, British anti-levisite or dimercaprol is contraindicated in cafe. What is cafe? Ca is cadmium, F is iron. So cadmium and iron poisoning, बाल is contraindicated. So cafe में बाल नहीं होना चाहिए. That is the answer. Next question, lignocaine is used in a loading dose for treatment of arrhythmias. Loading dose depend upon. So we all know the formula of loading dose is equal to volume of distribution into target plasma concentration divided by bioavailability, fractional bioavailability. Now what is important? So here the two options, one volume of distribution, second bioavailability is there. The answer is volume of distribution. The question is why bioavailability is not there? Because they are talking about lignocaine in arrhythmia that is given IV. So when we give IV, bioavailability is always 100%. So it will not depend because the route we are going to use is IV. So if it is bioavailability determine if we are using by other route. So here the main answer will be volume of distribution. Next question. A person was taking antihypertensive drug and continued taking it despite developing constipation, dry mouth and dizziness. So you need to know which antihypertensive drug caused these side effects. Second, he was taking it regularly but forgot to take it during a trip abroad and now developed hypertensive emergency. So this will clarify that they are talking about clonidine. We know clonidine, it causes dry mouth, blurred vision, constipation, and plus clonidine is safe in pregnancy. These we already discussed in our lectures. Clonidine is safe in pregnancy. Clonidine causes dry mouth, dizziness like side effects. Problem with clonidine is if we suddenly stop, clonidine can result in rebound hypertension. And this is important. That's why clonidine should not be given to people who have traveling job. If they forget to take, they can develop rebound hypertension as in this case. So it is a typical case of clonidine. Okay. Next question. A patient being treated for hypertriglyceridemia developed flushing, gout, hyperglycemia and raised liver enzymes. So all these are characteristic of, yes, it is about niacin or nicotinamide. So nicotinamide cause flushing and itching, which are the most common side effects of this drug. They are compliance limiting side effects. And apart from that, it can result in hyperuricemia, which can lead to gout. It can cause hyperglycemia and insulin resistance, and it is hepatotoxic also. Now you do not get confused that even statins can result in hyperglycemia and hepatotoxicity. But in statins, there is no flushing, no gout. And plus in statins, the most important will be myopathy. So that is not there. So answer is nicotinamide or niacin. Okay. Next question. Which drug when given with erythromycin causes QT prolongation? So this we discussed several times that drugs were banned many years ago because of this problem. Whenever they are given with enzyme inhibitors like erythromycin, they cause QT prolongation, which can lead to arrhythmias like torsades de pointes. And which drugs? They are called CAT drugs. So CAT drugs include cisapride, estamizole, and terfenadine. So we all remembered CAT is cute. So CAT drugs cause QT prolongation. So it is a direct question from the CAT drugs. So answer is estamizole. Okay. Next question. A 45-year-old male with history of chronic alcohol use is admitted to the hospital. He present with anxiety, tremor, agitation after his last drink 24 hours ago. So that means these are withdrawal symptoms. So which is most appropriate for withdrawal symptoms? So most appropriate drug for alcohol withdrawal symptoms. So how to manage alcohol withdrawal syndrome? Number one, we give benzodiazepines. Benzodiazepines, they are CNS depressant like alcohol. So they will suppress the symptoms. So among the benzodiazepines, mostly we use chlordiazepoxide. Even diazepam can be used. But if a person has liver disease, then we prefer lorazepam. So these are the benzodiazepines we prefer. So apart from that, we use sympatholytic drugs because in withdrawal, there will be sympathetic excess symptoms. So we can use beta blockers, we can use clonidine, and we can use a drug like clonidine specifically used for withdrawal, lofexidine. This is like clonidine. So they are used in withdrawal symptoms. So among the options, the answer is lorazepam. So do not get confused that the person is having anxiety, so we will give buspirone like drugs. No, they are not for anxiety. The question is asked about withdrawal symptom. Okay. So moving to next question. Which of the following statement about cyclesonide is incorrect? So what is cyclesonide? Cyclesonide is a steroid. It is known as soft steroid. What is the meaning of soft steroid is, normally when we give steroids by inhalational route, 95% of the steroid or any drug given by inhalational route deposit on the pathway. So only 5% reach the bronchus. So the 95% drug deposit in mouth, oropharynx, nasopharynx, larynx, all these places. So they can decrease immunity at that place. So that can result in increased risk of infection like oropharyngeal candidiasis. But what is special about cyclosonide? Cyclosonide is a pro-drug. That means it is not active. So when we are giving inhalational steroid in the form of cyclosonide, when it deposits on the way, it is not active at all. It is inactive. It is pro-drug. But inside the bronchus, it becomes active. In the bronchus, there is one enzyme called as esterase that will make it active. So activated inside the bronchus. So what will be the advantage? Yes, whatever is deposited is inactive, so that will not cause candidiasis. So it has much lesser risk of causing oropharyngeal candidiasis as compared to other inhalational steroids. Okay, so that is the main point. Now coming to the options, so we need to tell incorrect. Oral candidiasis is common, so that is again the first question, which is the answer. So it is not common, it is uncommon. It has fewer side effects than other inhalational steroids. Yes, that is correct. It is a pro-drug activated by bronchial esterase. Yes, correct. It has comparable efficacy to other inhalational steroids. Yes, it is an inhalational steroid. Answer is same. So answer is oral candidiasis is common with its use. Okay, next question. This is a repeat question we discussed several times. So from the line Weaver Work plot, you need to tell which is competitive, which is non-competitive. So very easy. We discussed if the graph is crossing at the y-axis, so you can remember C for cross. C means competitive inhibition. So here the graph is crossing at y-axis, so it is competitive inhibition. So answer is this. But if the graph start from x-axis, so this is the thing, and if the graphs are starting from x-axis, so one graph is going like this, one is going like this, then it will be non-competitive inhibition. So non-competitive, they start from one point on the x-axis. So you can remember that मेरे x दाता कोई competition ही नहीं, तो x-axis से start होंगे तो non-competitive. Okay, if they're crossing at y point, it is competitive. So answer is competitive inhibition. Next question, this we discussed in our videos. Why is atropine mixed with diphenoxylate? So what is diphenoxylate? Diphenoxylate is a drug used in treatment of diarrhea. But the problem is diphenoxylate is an opioid. Now we know in India it is very common that we normally go to pharmacist and ask that I have diarrhea, give me the drug. So if the pharmacist has only diphenoxylate and pharmacist give it to the person. Now the same thing it is now known by an addict, a person who is addict on opioid. He go to pharmacist, take diphenoxylate. He take one tablet but did not get euphoria because it is very less. So what he did, he take 10 tablets. Now he will mix all these tablets and take. Now he will get a kick. So that means there is a risk of abuse. There is a risk of addiction. So what we have done is we do not give diphenoxylate alone. It is always given in combination with very small amount of atropine, that is called as subtherapeutic dose. So we give subtherapeutic dose of atropine along with diphenoxylate. It is never available alone. Now what is the advantage? If a person take one tablet, person will get only diphenoxylate effective dose. The atropine dose is subtherapeutic, very less. So it will not cause any problem, not cause any side effect. So that means only we are taking it for diarrhea, treat diarrhea, no problem. But if a person is smart, person take 10 tablets. If the person take 10 tablets, the atropine will also add up. So when atropine add up, that will lead to side effects. So before the person get the euphoric effect, person develops side effects of atropine, dry mouth, urinary retention, all of these problems will occur which are not perceived good. So person will not like to abuse. So that is the main reason of adding atropine. Remember, atropine is anticholinergic, but it will also decrease GI motility, but it is not added for that purpose because the dose used is subtherapeutic. Okay, so the answer to this is atropine used to prevent the abuse of diphenoxylate. Okay, next question. A 25-year-old male present to clinic with complaint of burning sensation during urination and purulent discharge from the penis. So it is a type of sexually transmitted disease. Unprotected sexual intercourse, so that confirms it. On examination, urethral meatus, erythematous and noticeable purulent discharge. Gram stain shows intracellular gram-negative diplococci. So it is a gonococci. So it's very clear. So the diagnosis is gonorrhea. So patient is otherwise healthy, no allergies. So what is the appropriate treatment? Remember, drug of choice for gonorrhea, it is ceftriaxone or cephalosporin. But ceftriaxone given by injection. If the person do not want to take injection, we can give oral cefixime. So ceftriaxone was drug of choice, but here cefixime will be given because it is oral drug. And remember, benzathine penicillin G is for syphilis. This is not a case of syphilis, so answer will not be benzathine penicillin G. Metronidazole is used for other sexually transmitted disease like bacterial vaginosis, and doxycycline is used for conditions like lymphogranuloma venerea. Okay, the answer here is cefixime. Next question: a patient present with symptoms of tachycardia, tachypnea, hypertension and hypocalcemia after consuming an unknown substance. There is presence of high anion gap metabolic acidosis. So this is a typical of ethylene glycol poisoning. So what is typical of ethylene glycol poisoning? Number one, in ethylene glycol there is accumulation of, I will tell you the mechanism. Ethylene glycol, it is metabolized to form glycol aldehyde, which lead to conversion into glycolic acid, which is metabolized to form oxalic acid. So what happens? Because of accumulation of acids, there is high anion gap metabolic acidosis. So this is one thing which is given in the question. Number two, what happens is the oxalic acid, it form a complex with the calcium. So calcium oxalate. So the crystals come in the urine. Number two, because it binds the calcium, that lead to hypocalcemia. And number three, it is alcohol. So there will be symptoms of alcohol intake. So there will be tachycardia, tachypnea, hypertension. These symptoms are there. So what are pointing toward that? Metabolic acidosis, hypocalcemia and alcohol-like symptoms. So answer is ethylene glycol poisoning. Okay. Next question: in which phase of clinical trials dosing is determined? So read the question carefully. If they simply ask drug dosing, it is in phase 1. So if they ask maximum tolerable dose or drug dosing, it will be phase 1 clinical trial. But read carefully, if they ask which study is dose ranging study, read carefully the word dose ranging. If dose ranging is asked, it is phase 2. So here drug dosing is asked, so answer is phase 1. Okay. Next, methotrexate is a chemotherapeutic agent. It is work by inhibiting the senses. So basically we know methotrexate, it inhibits the enzyme dihydrofolic acid reductase. And this is finally involved in formation of thymine. So basically there will be deficiency of thymine monophosphate. So methotrexate acts by decreasing thymine monophosphate. Okay. Next question: a patient with HIV is currently on antiretroviral therapy consisting of zidovudine, lamivudine and nevirapine, is diagnosed with TB. So which drug should be changed? So we all know rifampicin is a powerful enzyme inducer. It increases the metabolism of several drugs, particularly NNRTIs like nevirapine. So it increases the metabolism of nevirapine. So they will become ineffective. So what we do, we change rifampicin to rifabutin if the person is taking nevirapine. But you also need to know certain other questions are asked from HIV and TB interaction. If a person is taking a regime called as TLE, tenofovir, lamivudine and efavirenz, these do not interact with rifampicin. So I will reorganize them and write it as let regime. So what we will say, let it continue. Even if rifampicin is given, continue same regime. But if the person is taking TLD regime, dolutegravir is taking, then D ko double kar do. So dolutegravir dose should be doubled. Dolutegravir dose is doubled, rest remains same. But if a person is taking protease inhibitor or the person is taking nevirapine, then we do not use rifampicin. So change rifampicin to rifabutin. So these are the guidelines you need to remember for TB and HIV. So answer here is rifampicin. Okay. Next question: which is used for maintenance therapy in opioid abuse? So basically maintenance, typically we were using methadone maintenance therapy. The another drug we can use is buprenorphine. So what are these? These are long-acting opioids. So whenever we want to produce de-addiction, we stop giving the addictive opioid and start giving these drugs. So the person is maintained, person do not develop withdrawal symptoms. So this is number one. Number two, to treat the withdrawal symptom. To treat the withdrawal symptom, we give the drugs according to symptoms. Like if there are seizures, we can give diazepam, benzodiazepines like drugs. If there are sympathetic symptoms, we can give clonidine like drugs, beta blockers like drugs. They are used to treat these symptoms. And third very important question asked is, which is used to prevent the relapse? In case of opioid addiction, the answer is naltrexone. Naltrexone is used to prevent the relapse. So all three questions are very important and that we discussed in our videos also. So here the answer will be buprenorphine. Okay. Next is, caffeine is a widely used stimulant. How it produces wakefulness? So wakefulness. So we know caffeine, it has several mechanisms. Like theophylline, caffeine has three prominent mechanisms. One, it inhibits phosphodiesterase enzyme. Number two, it is an adenosine antagonist, adenosine A1 receptor antagonist. And number three, it also releases norepinephrine from locus coeruleus. Now, how to maintain wakefulness? The most important will be adenosine antagonism. Remember, I told you adenosine antagonism produce side effects, which is remembered as first three letter of adenosine. So A for arrhythmias, D for diuresis, and E for epileptic seizures. So epileptic seizures means it will stimulate the brain, so it promote the wakefulness. So the main mechanism is adenosine antagonism. This can also cause, but the main mechanism they have asked, that is adenosine antagonism. Next question. Here, a small child, 6-year-old child has developed PSVT. So the question asked is, what is the dose of adenosine? So remember, the dose of adenosine in children is first time when we want to treat for PSVT, the dose is 0.1 milligram per kg, but the maximum limit is 6 milligram. So we will not give more than 6, we give IV. But if repeated dose is required, first dose is not able to correct. So the repeat dose is higher. It is 0.2 milligram per kg with a maximum of 12 milligram. So in adults, it is directly 6 milligram, 12 milligram. In children, it is 0.1 or 0.2 milligram per kg. Okay. The answer here, initial recommended dose, the answer will be 0.1 milligram per kg. Next question. A 65-year-old patient present with symptom of bone pain, anemia, hypercalcemia, renal impairment, biopsy confirmed multiple myeloma. So person is having multiple myeloma. Person was started on treatment, which is most likely to be associated with reactivation of herpes zoster. Remember, many drugs which are immunosuppressant, they can lead to reactivation of herpes zoster. And among multiple myeloma drugs, almost all the drugs can lead to reactivation of this herpes zoster. But the question which is most important, so most likely it should be bortezomib. Bortezomib is a proteasome inhibitor. It is an immunosuppressant drug, suppress the immunity, and there is risk of reactivation of herpes zoster. Next question, which of the following is a selective norepinephrine reuptake inhibitor? Remember, it is not serotonin and noradrenaline reuptake inhibitor, it is selective norepinephrine reuptake inhibitor used for ADHD. The best answer to this question should have been atomoxetine. But atomoxetine is not in the options. So we need to choose the next best option. The next best option is reboxetine. Remember, reboxetine is the only option which is selective noradrenaline reuptake inhibitor. No other drug is selective noradrenaline reuptake inhibitor, but the problem is reboxetine, it is offline used, off-label used for ADHD. It is not approved for treatment of ADHD. It can be used off-label. Now, regarding other option, particularly methylphenidate, methylphenidate is not selective noradrenaline reuptake inhibitor. It is dopamine and noradrenaline reuptake inhibitor. Then guanfacine is not used. It is basically alpha-2 agonist. It is not reuptake inhibitor. And modafinil is, again, it is an amphetamine-like drug. So it is not inhibiting the noradrenaline reuptake specifically. Plus, modafinil is used for mainly narcolepsy. Okay, so the answer to this is reboxetine. Next question. 18-year-old boy from Rajasthan weighing 50 kg is diagnosed with mixed Vivax and falciparum malaria. What is the appropriate treatment? Now let's discuss the treatment of malaria. If there is Plasmodium vivax malaria, Plasmodium falciparum malaria, or if there is mixed malaria. So treatment of choice for Plasmodium vivax malaria is chloroquine. Chloroquine is the drug of choice, and it is followed with primaquine, which is given at a dose of 0.25 milligram per kg. Maximum dose is 15 milligram. In adults, remember 15 milligram. It is given for 14 days. Remember, in Vivax, we have to kill the hypnozoites. We want to prevent the relapse. That means radical cure. So answer is primaquine for 14 days. The dose is lesser because we are giving for long period. On the other hand, in Plasmodium falciparum, the treatment of choice is ACT. And we know ACT is of two types. What are the two types? One, in the northeastern states, we use artemether. Northeastern states, we use artemether plus lumefantrine. But all other parts of the India, we use artesunate plus sulfadoxine pyrimethamine. Artesunate plus sulfadoxine pyrimethamine. But how to use this is, the artesunate is given for 3 days, whereas sulfadoxine pyrimethamine is only first day, one tablet only. Then second thing, apart from this, we also give primaquine, but the role here is different. It is mainly to kill gametocytes, and the dose is 0.75 milligram per kg, and that is given only for single dose on day 2. Okay. Now, if it is a mixed thing, then combination will be given. That means ACT as discussed in falciparum, but primaquine as discussed in Vivax, that means 0.25 milligram per kg for 14 days. So that is the important thing you need to understand. Now coming back to the question. So in the question, it is a mixed malaria. Mixed malaria means, that means we have to give ACT and primaquine for 14 days. Then second thing is, it is from Rajasthan, so ACT will include artesunate plus sulfadoxine pyrimethamine. But what is important thing, sulfadoxine pyrimethamine is given only on first day. So that means the question asked is on day 2. So sulfadoxine pyrimethamine has already been given. So what is remaining? Remaining is artesunate and primaquine. So the option will be artesunate plus primaquine. So option is either A or B. So sulfadoxine pyrimethamine has already been given. C and D cannot be the option. Now second thing, the dose of artesunate is 200 mg. That is already given. But dose of primaquine. So primaquine here, it is because for 14 days we need to give. So the dose is 15 milligram. 2.5 milligram into 6 tablets. So it is 15 milligram. So answer will be A here. Okay. Next question. Which is a growth hormone analog not used for growth hormone deficiency but used for HIV associated lipodystrophy. So just you need to remember the name. It is tesamorelin. It is a growth hormone analog used for HIV. It is HIV lipodystrophy treatment of direct question. Next is, a 45-year-old patient with history of depression was initially treated with sertraline, which is SSRI. But his symptoms were not adequately controlled. His medication regime was changed to include MAO inhibitor and amitriptyline. So when we give MAO inhibitor with amitriptyline, what happens? So amitriptyline acts by increasing serotonin, and MAO will inhibit its metabolism. So there will be lot of serotonin, which lead to serotonin syndrome. So they have given the clinical features of serotonin syndrome like agitation, seizures, hyperreflexia and tremors. It is serotonin syndrome. So what is the treatment? Remember, serotonin syndrome is treated by a serotonin antagonist, and the important antagonists we can use are cyproheptadine or ketanserin. So any of them we can use for serotonin syndrome. So the answer to this question is cyproheptadine. Lorazepam is not the answer because of seizures only. It will control only seizures, but other features cannot be controlled. So lorazepam is not the answer. L-carnitine is used for valproate hepatotoxicity, hyperammonemia. It has no role here. And leucovorin is for methotrexate toxicity. So answer is easy. It is cyproheptadine. Next question. A patient of eclampsia is being treated with magnesium sulfate, which is an indication to stop. So basically, we want to prevent the magnesium toxicity. So we need to monitor certain things. So what are the things we will monitor when we start magnesium? Most important will be urine output. Urine output. So if the urine output is less than 100 ml in the last 4 hours, it is an indication to stop giving magnesium. So this is number one. Apart from that, we will monitor the respiratory rate. If the respiratory rate is less than 12, it is an indication for stopping the magnesium. Apart from that, we will also monitor the deep tendon reflexes. Normally, they will be abolished, but there is no such indication. They are the first to go. So they are giving an reason that it may lead to magnesium toxicity. Clear? So these are the main things we monitor, and plus in late stages, there will be cardiac problems. Late stages, there will be cardiac problems. Okay. So now if we see the options, when we want to stop respiratory more than 18, no, respiratory rate lower is a problem. If it is less than 12, that is a problem. More than 18, no problem. Exaggerated deep tendon flexor will not be seen. Deep tendon flexor will be abolished. Urine output less than 60, yes, it is an indication. If it is less than 100, we need to stop. Presence of visual disturbances, so there is no visual disturbance in magnesium toxicity. So answer is urine output less than 60. Okay. Next question, a 32-year-old female, late pregnancy, again same magnesium question. So question here is, which parameter does not require routine checkup? Routine checkup. Urine output, yes, we just discussed, less than 104 hours, we need to stop. Deep tendon flexor, we need to monitor to know the early toxicity. Magnesium levels routinely are not needed. If we are suspecting a toxicity, only then we check the magnesium levels, otherwise routinely we do not check. And respiratory rate, again just we check, less than 12 is a problem. So answer is serum magnesium levels are routinely not required. Next question, a 30-year-old addict present to emergency department, signs of unknown drug poisoning. The patient exhibit dilated pupil. Yes. Diaphoresis, sweating is there, tachycardia is there, and tremors are there. So basically sympathetic symptoms are there. On examination, BP is high and heart rate is high. So what is the likely diagnosis? So do not get confused with Dhatura just by dilated pupil. Remember, dilated pupil, tachycardia will be seen in Dhatura, but Dhatura cannot explain tremors. Dhatura cannot explain diaphoresis. Rather, it is opposite. There will be dry mouth. Dry mouth will be there. Diaphoresis will not be there. And plus, there is hypertension. So basically, it is a sympathetic symptoms. So what is happening? The person is having sympathetic symptoms. So the question asked is, which addictive drug causes sympathetic symptoms in overdose? The answer is cocaine. Remember, cocaine addiction. Cocaine is a reuptake inhibitor of noradrenaline. So excessive cocaine can lead to sympathetic symptoms. So answer is cocaine intoxication. Okay. Next question. A pregnant female at 37 weeks of gestation comes with history of prosthetic heart valves. She is taking warfarin. So what to be done? So remember, if a female is already taking warfarin in second trimester, so if we see the 3 trimester, first, second and third, in first trimester, warfarin is contraindicated. Only we need to give low molecular weight heparin. In third trimester, after 37 weeks, we need to give low molecular weight heparin. In second trimester, we can use low molecular weight heparin, but we can also use warfarin up to 36 weeks. Okay? Normally, we prefer low molecular weight heparin. But if a female is already taking warfarin, then we will not stop her. We will ask that continue till 36 weeks. At 37 weeks, come with to low molecular weight heparin. Clear? So here the female is coming at 37 weeks. So we will advise to change to low molecular weight heparin, switch to low molecular weight heparin. But had she been in second trimester and taking warfarin, we will not say start just now. So we will say continue till 36 weeks, then change to heparin. Otherwise, heparin is the best answer now. Okay. Next question. A 25-year-old male presented to emergency with head trauma and with road traffic accident. There is cerebral edema. So this is a direct question. Drug of choice for cerebral edema is mannitol. Osmotic diuretics like mannitol are drug of choice for cerebral edema. Okay, so these are the important questions of NEET PG 2024. Thank you very much.